Welcome to The Explainer. Today we are tackling a topic that is just absolutely fundamental to medicine: anemia. Seriously, for any medical student, any resident out there, getting a solid handle on this is completely non-negotiable. Why? Because you're going to see it all the time. Okay, let's get into it. So here's our game plan. We're going to build this up, layer by layer. We'll kick things off with a really solid definition, then we'll build a framework so you know how to think about the causes. From there, we'll dive into the big categories with some classic examples. And at the end, we'll pull it all together into a clinical takeaway that you can actually use.
All right, first things first, what even is anemia? You know, it's so easy to just see a low hemoglobin number on a lab report and stop there. But it's so much more than that. It's really about function. That last part right there, that's the key. Reduction of the oxygen transporting capacity of blood. See, anemia isn't really a disease in and of itself. You should think of it more like a sign, an engine warning light on the body's dashboard. It's telling you something is wrong with the ability to get oxygen to the tissues. And our whole job, is to figure out why that is happening.
So to figure out that why, you can't just guess. You need a system, right? A framework that lets you approach any case of anemia logically. This is all about getting to the root cause, the actual mechanism that's gone wrong.
And here it is. It's actually kind of beautiful how simple it is. Pretty much every single type of anemia you'll ever encounter boils down to one of these three main problems. You've got blood loss, super common, and we'll see how that leads to iron deficiency later. But for this explainer, we're really going to focus on the other two to understand the deep pathology. Either the red cells are being destroyed way too fast, or the bone marrow factory just isn't making enough of them. This is the foundation for everything we're about to cover.
Now, when clinicians approach anemia, they use two main lenses. There's morphology, which is all about what the red cells physically look like. Are they big, small, pale? Then there's pathophysiology, which is the why we just talked about. We're going to lean heavily on the why, because honestly, if you understand the underlying mechanism, the way the cells look just makes perfect sense. It all clicks into place. But of course, the look is still incredibly important for clues. These lab values, the MCV, MCHC, and RDW, these are our first hints. Think of them as the vital signs for your red blood cells. MCV tells us their average size, MCHC tells us how much hemoglobin is packed inside, and RDW tells us if the cells are all nice and uniform or if there's a wild mix of different sizes. These numbers are the breadcrumbs that start us on the right trail. Okay, let's dive into our first major bucket: increased red cell destruction. We also call these hemolytic anemias. In these diseases, red blood cells are not living their full, happy 120-day life. Nope, they're getting destroyed way ahead of schedule. A perfect example of this is hereditary spherocytosis. It's a genetic problem where the proteins that create the red cell's inner skeleton are faulty. So without that strong internal scaffolding, the cell membrane becomes unstable and it starts losing little bits of itself. Now here's the cool part. The cell is losing surface area, but not its internal contents, not the hemoglobin, so what's it do? It has to ball up into the most efficient shape possible, a sphere. And because all that hemoglobin is now packed into a smaller volume, its concentration goes up, which is why we see a high MCHC on the lab report. And right here on this slide, you can see exactly what that looks like. It's fascinating. Check out these cells. They're small, they're dark, and they've totally lost that pale spot in the middle that normal red cells have. That, right there, is the spherocyte. It's the visual signature of the disease. So what's the big deal about being a sphere? Well, the consequence is huge. A normal red cell is this beautiful, flexible disc that can squish and squeeze through the tiny blood vessels in the spleen. But these spherocytes, they're rigid, they're stiff. They can't make the tight turns, so they get stuck. And when they get stuck, the spleen's macrophages see them as defective and just eat them. That's a classic example of what we call extravascular hemolysis. Okay, let's look at another giant of hemolytic anemias, sickle cell. This time the problem isn't the membrane, it's the hemoglobin molecule itself. A single tiny mutation creates something called hemoglobin S. Now, when it's carrying oxygen, it's totally fine. But when it drops off that oxygen, especially in low oxygen environments, something dramatic happens. The HbS molecules start sticking to each other, forming these long, rigid polymer chains inside the cell. And boom, this slide shows you the results of that polymerization perfectly. You can see it right there, clear as day. that classic, stretched out, sickle-shaped cell mixed in with the normal round ones. That one cell is the entire reason for the name of the disease, and it's the source of all the terrible problems that follow. That sickle shape causes a devastating 1-2 punch. First, those rigid cells are incredibly fragile. They break apart easily, which leads to the chronic anemia. But second, and this is what causes the most acute problems, they're sticky and stiff, and they logjam in tiny blood vessels, creating a blockage. That blockage cuts off blood flow, starves tissues of oxygen, and leads to the absolutely excruciating pain crises that define life for these patients. All right, let's switch gears and move to our second major category. We're shifting our focus now from problems of destruction to problems of production. Think of it this way. Now the issue isn't on the battlefield, where cells are dying. It's back at the factory, the bone marrow, which is struggling to produce enough healthy cells in the first place.
This right here is such a high-yield concept. If you just look at a blood smear, these two conditions can look almost identical. You'll see small, pale red cells in both. But the root cause, their pathophysiology, could not be more different. Iron deficiency is a straight-up supply problem. The factory has run out of a key raw material, iron. But with anemia of chronic inflammation, it's a logistics problem. The iron is in the warehouse, but inflammation has locked the doors, and the factory workers can't get to it to make new cells. So if they look the same, how on earth do you tell them apart? With these lab tests. Just look at the serum ferritin. That tells you how much iron is in the body's storage tanks. In true iron deficiency, the tanks are empty, so ferritin is low. But in chronic inflammation, the tanks are full. The iron is just locked up, so ferritin is normal or even high. This one test is often the absolute key to cracking the case.
And this is that classic picture of iron deficiency under the microscope. You can just see it. The cells are obviously smaller than normal, that's what microcytic means, and they have that big, washed-out pale center. That's hypochromic. It all makes sense, right? The factory has less iron, so it can't pack each red cell with enough hemoglobin. What's the result? You get a low MCV and a low MCHC. The factory is making smaller, paler products. Okay, let's take a slight turn here, but stay within this idea of a factory problem. We've talked about not having the raw materials to make hemoglobin, but what happens if the factory has all the materials, but it can't read the blueprints to make new cells? What happens when it can't build DNA? Well, that leads us to megaloblastic anemia. The central issue here is a breakdown in DNA synthesis, and it's almost always because of a deficiency in vitamin B12 or folate. Without these critical building blocks, cells that need to divide quickly, like all those blood cell precursors in the bone marrow, they just can't replicate their DNA correctly. So this DNA problem creates some really specific, kind of weird-looking cells. The nucleus gets stuck and can't divide properly, but the rest of the cell, the cytoplasm, it keeps on growing. And what does that give you? These huge, abnormal cells. And here is a massive clinical pearl for you. The very earliest sign you might see in the blood is the hypersegmented neutrophil. If you see a neutrophil with 5, 6, or even more lobes, that is a huge red flag for a DNA synthesis problem, and it can show up even before the anemia gets really obvious. Okay, so we've been through destruction, we've been through underproduction. Let's tie this all together now. What does this all mean for you as a student, as a clinician, at the bedside?
And for me, if you take away only one thing from this whole discussion, let it be this. When you see a lab result that says anemia, your job isn't over. Your job has just started. That low hemoglobin number is not the diagnosis. It's a signpost. It's pointing you down a path, and your job is to follow that path and uncover the real story. Is the patient bleeding somewhere? Are their cells being destroyed? Or is the factory just not working? So, never forget that. Anemia is never the final answer. It is always, always the beginning of a question. And the real question you have to ask yourself is, what is the body trying to tell me? What is the real story here? If you can answer that, you're well on your way.